Good evening, everyone. On behalf of eGurukul Pathshala team, I welcome you all to the case presentation on central nervous system today. Thank you for joining us. Today we have case presenter from Pramukh Swami Medical College, Karamsad, and we have Shweta Panchal presenting case, and she is being mentored by Dr. Dipali Shah, who is assistant professor from Pramukh Swami Medical College, Karamsad. As expert, we have Dr. Debasi sir. Sir is a consultant pediatric neurologist at Ankura Hospital, Bhubaneswar. Sir is ex-EB member from East Zone to Association of Child Neurology India. He is member of Autism Board, Odisha, has many publications, and he has special interest in epilepsy, genetics, autism spectrum disorder. We welcome you, sir. Thank you for accepting the.
Thank you. Thank you so much for it.
We are fortunate enough to have our own professor, Dr. Baldev Prajapati, sir. Sir always blesses us with all the knowledge, and we are really fortunate to have him for all the meetings, and we are very happy to learn from him. I hand over to Baldev, sir. Thank you.
Good evening, friends. Welcome to this our Saturday PG Clinic by Gurukul Pathshala. I request all the students on the screen that please keep your video on and participate in the discussion very freely. Whatever point comes to your mind or any question, any comment, because that will be very important for learning for all of us. Of course, we have Dr. Devasi as the expert. Something really confusing to us will take his help, but I'm sure that the more interactions, more learning. I request Dr. Shweta to share her PPT with the history. Dr. Shweta, please.
Yes, sir.
Yes, Shweta, go ahead.
The slides are visible?
Yeah, yes. Even full screen.
Okay.
Fine.
Myself, Dr. Shweta Panchal, third year pediatric resident, and under Pramukh Swami Medical College, Karamsad, under the mentorship of Dr. Dipali ma'am. I am presenting the CNS case. Presenting a case of 2-year, 6-month-old male child named XYZ, born by a non-consensuous marriage, residing at Sojitra Anand, Hindu by religious, belonging to lower socioeconomic class according to modified Kupuswami classification, brought to the pediatric department of Sri Krishna Hospital by his parents on 29th April 2024. Informant are parents, date of admission 29th April and date of examination 23rd June. As the complaint of child was since long duration, hence I would like to start my history from day 1 of illness, 3 months back from the day of history take. Child was apparently 3 months, complaint of fever of 1 month duration, vomiting 3 to 5 duration after 15 to 20 days of fever, 6 to 7 episodes in a single day, decreased limb movement over left side of body after 10 to 12 days of vomiting, followed by abnormal movement 3 to 4 episodes in a single day. History of presenting illness. Symptoms started with fever of 1 month duration in month of March, which was initially low grade, non-documented, intermittent.
Shweta, your slide is not changing. Shweta, your slide is not changing. Yes, now it has come.
History of presenting illness. Symptoms started with fever of 1 month duration, which was initially low-grade, non-documented, intermittent. Child was active during interfebrile period. Fever was not associated with rigors. Fever more during the evening, temporarily relieved on taking oral medication from nearby hospital. After 5 to 7 days of illness, fever frequency and duration was increased. Now fever was high-grade, associated with reduced oral intake. Child was active during interfebrile period, temporarily relieved on taking medication. After taking medication, severity of fever was reduced, but as per the mother, child never become febrile in 1 month of duration, even after taking medication. After 15 to 20 days, again severity of fever increased, and now child developed complaint of vomiting, which was acute in onset. episode 6 to 7, small in amount, projectile in nature, contain water and food particles, non-bloody, non-bilious. For that, taken to some hospital where child was admitted for 3 days and management were given. After discharging from hospital, child continued to had intermittent low-grade fever. Child was not playful as per the mother. Mother noticed that gradually child's condition worsened in last 10 days after discharge. Mother noticed reduced activity of left side of limb compared to the right side.
You can take it further.
Yes, sir. Mother noticed the reduced activity of left side of limb compared to right side, which was acute in onset. Weakness were noticed by the mother in form of not able to hold the object with left hand, not lifting the left arm above the head, and could not bear his weight on the left leg. Which was associated with not able to speak except screaming some sound. After 2 to 3 days of weakness, child developed altered sensorium in form of progressive decrease in level of consciousness. Child was confused initially, not interested in surrounding, then slowly become drowsy in form of not responding to verbal stimuli and intermittently become sleepy. After 2 to 3 days of weakness, abnormal movement in form of tonic posturing of left upper and lower limb associated with clenching of teeth, uprolling of eyeball, which was not associated with proceeding from mouth, not associated with stool or urine passage, lasted for around 4 to 5 minutes, relieved by its own, followed by postictal phase of drowsiness. 3 to 4 such episodes with similar semiology occur every day, then progress to involve all four limbs in form of generalized tonic-clonic movement, which was associated with uprolling of eyeball, clenching of teeth, lasted for around 4 to 5 minutes and relieved by its own. 3 to 4 such episodes occur every day. All of this above mentioned complaint associated with weight loss as per the mother on asking loosening of clothes. Sir, should I proceed?
Is there anything, I think, in the history part?
Sir, history of presenting illness.
Okay,
over.
I think okay, negative history will do later on. You can stop sharing.
Okay, sir.
First, I request everybody to keep their video on because I'm not able to see that who are they. Please, yes. Dr. Sandeep, Dr. Aditi, Dr. Dimpal, Divyanshi, please keep your video on. I think Dr. Shweta has provided good information. Let us try to understand that what she wants to convey from this story. Dr. Neely, can you give this exact capsule of the discussion or the narration what she has made? What you understood? First, unmute yourself. Yes.
Yes, sir. So this patient had fever since past 1 month. Initially, the fever was low grade to moderate grade.
I think
And
all
in the
the
last-
Lily, all the points she had described, all of us have
Okay.
attended. Now from that,
Okay.
you can put the story that what you are able to make the inference.
Okay. So there was fever since past 1 month.
Right?
After which there was vomiting for past 1 week. After which there was left-sided weakness, altered
Right.
sensorium, and 4 to 5 episodes of abnormal movements.
Very good.
So, which landed the patient in our hospital.
What you understood from this description?
So I'm understanding that there should have been some infection at other place somewhere in the body, which has now spread to the CNS, and it has spread to the CNS in such a way that it has caused a left-sided weakness along with some seizures.
Somebody, if I directly come to a question, that
Yes.
left-sided weakness, what does it indicate?
So left-sided weakness would indicate that there is some injury in the right-sided cortex.
Where?
Or right, right-sided pyramidal fibers of the brain before deposition.
What is the likely site of laser? Suppose you just think, I will say compartment wise. If
Okay.
I ask you to focus only the weakness on the left side, right? She described very nicely that gradual weakness develop and then child was not able to perform on the left side,
Yes.
right? And if you understand that, first always try to think where is the anatomy, what is the site of laser. For this particular weakness I'm asking, not for other things. Take one by one. Where the lesion should be there, which will result in the weakness on one particular side of the body.
Um,
Anybody else? Dr. Divyanshi, come on. I'm not sure why they are not keeping that video on. Just by putting the name, hardly it makes any difference. You know, to participate in the discussion. I think Dr. Kajal. Yes, Dr. Dimple. Come on. My questions will be very simple. Try to understand, try to respond. First, I want to know that suppose any child, here the child complained of the weakness on the left side, left upper limb, lower limb together. Initially some weakness, then he gradually progressed and child was not able to perform on the left side of the body. Suppose if I focus on that particular point, what does it indicate? That where is the problem? Which part of the nervous system is affected? Try to think only the anatomy. Then we'll go further. First, Dimple.
Sure, in court.
Possibly motor cortex.
I think, Dimple, you must be sitting together, 2-3 friends. And then multiple, I will say, laptops or mobiles must be on. So I think you can make it off, and the person who is speaking, only one particular you can use. So no problem. Just ask your other colleagues to make it off.
So possibly it's a motor cortex.
Okay, I think you can manage your laptop or mobile till that I think Nili was trying to answer something.
Yes, sir. So I was saying the frontal cortex, the motor area present in the frontal cortex.
Now I will give the idea. Suppose if the weakness is due to cortical involvement, if I remind you the first MBBS anatomy, what we have learned that there is a representation of all the parts of the body for the motor activity differently. Right, from front it starts lower limb, then gradually goes upper limb, then trunk, and then face. I think that representation in the cortex we have understood. I'm trying to reminding you. Now suppose the whole side, left side suppose totally affected. And if I'm thinking the cortical lesion, then I think the whole one hemisphere should be affected. It should be very wide lesion. Then it is possible. I think if it is so, it will be really very big catastrophe. It is not so. So then where the lesion should be there? Where
internal capsule area?
Try to understand. More compact fibers, pyramidal tract fibers, they are very close in the bundle, which are affected. Then I'm sure that this is the presentation and somehow Neely is able to answer. Maybe the internal capsule. Very good. You know, gradually try to understand. We are not concerned with the case. We are not concerned with the diagnosis. I do not know even which system or what problem is going on. Suppose if we believe Neely that she is right, suppose internal capsule. My next question, what type of the pathology can do the damage in this way?
Vascular pathology.
Okay. Shweta, why not I will say infective? Why not traumatic? Why not autoimmune? Why not I will say
so-
degenerative disorder? They can also involve the pyramidal tract fibers. So what is your answer? Why you are coming directly to the vascular? I know you must be knowing the MRI report, which I do not know. I understand.
So if there is an infective involvement, then the duration of illness will be chronic phase, longer duration of illness. Then patient acquire the infection, then they reach the central nervous system where there is a focus, and then the focus will be discharging continuously and patient presented with us the symptom.
If I come directly to the question, why vascular? Why your spontaneous response was there vascular? How will you explain vascular? That's my question. And the vascular also in which form? That will be the next question, but why vascular? Try to remember that what the disease pattern, how they present. Any trauma will be sudden, acute. Suppose some road accident. Right, previously, few minutes back, person is normal. After the trauma, significant loss. That is the story of the trauma. Congenital malformation will be different since birth some problem is there. Somehow it was not there. Infective, yes, but the infection takes few days. And then it will be diffuse lesion. Vascular particularly may be in very acute lesion. Therefore, always remember acute, subacute, chronic. It is recurrent, it is static, it is progressive, it is slowly progressive, rapidly progressive. Try to find out this adjective, that will give the idea. Vascular always we understand that there will be the acute. In acute also, what is the characteristic of thrombosis, embolism, hemorrhage? Who will explain me? I want the comments from the students. What is the presentation from which you can suspect that this is hemorrhage, this is thrombosis, this is embolism? What will be the presentation? Anybody? Dr. Aditi, can you take it?
Presentation of hemorrhage will be acute.
Yeah.
So patient will deteriorate rapidly.
Very good.
Thrombotic symptoms will have a gradual progression.
Yeah. And embolism?
Embolism.
I think she is trying definitely good. Most commonly you must have heard somehow hemorrhage may not be common in our pediatric practice, but in the adults you must have heard old age person. Therefore, there may be the atherosclerosis, maybe the hypertension. Suppose somehow not manage hypertension properly. What story you are getting that the person was fine in the morning reading the newspaper or taking the cup of tea. He was talking and suddenly developed a severe headache and loss of even the functions, and now the patient is critical. That story indicates the hemorrhage. Thrombosis will be there, but not so rapid. It will be slowly. May complain some weakness for a few days, then weeks, gradually, because thrombosis gradually developing and then causing this neurological compromise. Embolism we know, it's suppose a case of ferrotetralogy or even mitral stenosis with back to endocarditis. The vegetation is detached in the circulation, lodged in the vessels, and suddenly complains of the weakness. That is the classical story of the embolism. Sometimes thromboembolism may be the common. That of the story. I think here also what Shweta complained. Initially, child complained of the weakness of some left side, upper limb, lower limb, not able to walk. So probably it should be some obstruction vessel involvement. Now suppose, so here let us keep it this way. That left side involvement, that means internal capsule, lesion should be the right side. vascular involvement in which vessel? Anatomy. Which vessel involvement? Supplying the internal capsule, which will present in this way. Even that's why I'm telling what we decide clinically, MRI finding should be the same. MRI will not, I will just help me. Clinically, I will decide that what MRI should show. And most of the times we are right. Provided we go for the clinical dissection appropriately. Which vessel is supplying to internal capsule? Come on. Anatomy.
Middle cerebral artery.
Middle cerebral artery, so many vessels, but mainly the supply. That means middle cerebral artery is likely involved. Here clinically, just from 2 slides we are thinking. With more information, our thoughts may get changed. Now we go further. Before that, the child was having the fever. 1 month duration. Going on, some family physicians, so many people treated. So what does it indicate, Dr. Dimple? Presence of fever for 1 month, what does it indicate?
It would have probably been.
I think anyway.
It would have probably been some chronic pathology, so not an acute infection.
Rather than Dimple, don't decide your mind from the I will say beginning. Don't get biased. My simple answer, presence of infection, that means it should be very simple, infection.
Active pathology.
Anyway, sorry for the interruption. There was some. Anyway, so fever indicates infection. Now with the fever, there was vomiting. Then altered sensorium. Aditi, what does it indicate? Come on. Now focus over the fever. Vomiting, I think 2.5-year-old child may not complain of headache, but maybe irritable. Suppose if you put all the points together, fever, vomiting, irritability, altered sensorium, what does it indicate?
The patient had infectious etiology, then sir, leading to raised intracranial pressure.
Very good.
That may be the reason of vomiting.
And altered sensorium?
Following which, sir.
What does the altered sensorium indicate?
Discovery.
Very good. I will be.
Cortical involvement.
I want to sensitize all of you from this point of view. It indicates encephalopathy. Right. Likely because cerebral dysfunction, altered sensorium, with fever. So fever, vomiting, irritability, probably that means infection. Infection has caused the raised intracranial pressure. Even maybe the raised intracranial pressure responsible for now even seizures. Right. Altered sensorium and seizures. That means some condition likely infective in origin, causing the raised intracranial pressure, cerebral encephalopathy, and with that even the raised intracranial pressure. Now, if you put as a whole, anatomy, again, go back to the anatomy. I think any system, think first anatomy, second pathology, third, try to define the etiology, which may not be possible every time from the history, and even the status of the function of that particular organ. Now, if you try to answer, certainly you can say that it's not acute, but subacute. It's a subacute febrile encephalopathy with raised intracranial pressure, and that indicates diffuse cortical lesion. It's a diffuse cortical lesion, maybe following some infection. But at the same time, already we discussed that there is a weakness on the left side. That means right side, the internal capsule, middle cerebral artery involvement. I think this much fully from 2 slides. So this is pathology. If somebody is asking you etiology, can you make the comment? That which etiology? Which presents in a subacute way, slowly progressive, infective origin, resulting in increased intracranial pressure, and even the encephalopathy. What common etiology will consider? Okay, tuberculosis, I think, common. Then can you, suppose if somebody asks you directly that vascular involvement, how will you explain in tuberculosis, which you are thinking that middle cerebral artery is involved? What will be a probable explanation? Is it thrombosis, embolism, hemorrhage, or what, or something else? Lily, what is your idea? Yes, Aditi. Aditi, come on. Aditi, but due to what? Due to what? Why the vessel is involved? Vessel involvement, in fact, it's just a different story. But how the vessel is involved? Suppose if you are thinking for tuberculosis, it's a vasculitis. Vasculitis. That is known due to tuberculous protein. So I think simply, and one more point what she mentioned, weight loss. Right. And when you are thinking for the tuberculosis, I think weight loss may help you. But somebody will define what is the weight loss, significant weight loss in the reference to tuberculosis. Who will define? Dr. Sandeep?
More than 5% of
5%?
Yes, Aditi?
So more than 5% in 3 months of duration.
Okay, good. Try to come to the very precise point if you want to score. Right. That weight loss more than 5%.